Welcome, everyone. I want to thank you all for coming and joining Temple University College of Public Health and the Friday Research Seminars. We have been grateful for Dr. David Sarwar, who has welcomed our trauma work group, a group of interprofessional represented faculty across the university here at Temple, to offer seminars each semester about trauma, to increase trauma awareness, and to help folks start to think about how to embody trauma-informed thinking in the spaces and places with individuals, communities, systems, organizations, policies, everywhere that we work. So it's my delight today to welcome Dr. Laura Cinco and Dr. Crystal Austin as our speakers today. Dr. Laura Cinco is an assistant professor in the Department of Nursing at Temple University in the College of Public Health. She is a former child and adolescent mental health nurse and is currently practicing sexual assault nurse examiner in Philadelphia. Prior to joining Temple, Dr. Cinco completed a postdoctoral fellowship, research fellowship, and a Master's of Science in Health Policy through the University of Pennsylvania's National Clinician Scholar Program, an interdisciplinary fellowship focused on healthcare policy and social change. Dr. Cinco received her bachelor's and doctoral degree in nursing at the University of Michigan, Ann Arbor, where she was a part of the Hillman Scholars Program in Nursing Innovation, an accelerated BSN to PhD program dedicated to making healthcare more effective, patient-centered, and equitable. Dr. Cinco's research focuses on promoting healing after gender-based violence, with a particular emphasis on social, cultural, and structural influences of recovery across the lifespan. Her work has been conducted domestically in both the campus and community setting, as well as internationally through a multinational gender-based violence research collaborative called Me Story. Dr. Cinco is also interested in the role of restorative justice as it relates to sexual harm and has received a certificate in restorative justice implementation and leadership from the University of San Diego. Dr. Cinco is passionate about creating research translation as well as research that is trauma-informed and healing-centered. She has expertise in both narrative and photography-based qualitative methods and has organized multiple community exhibitions to share her research, as well as the healing journeys of the survivors she has interviewed. Ultimately, Dr. Cinco is interested in leveraging creative, survivor-centered research to bridge the gap between survivor lived experience, the scientific community, and policymakers. By amplifying these perspectives, Dr. Cinco's goal is to create a more supportive, healing world for survivors of violence and abuse. Please also welcome me in joining Dr. Crystal Austin. Dr. Austin's clinical and research interests include exploration of intersecting identities, biracial identity experiences, race-based traumatic stress, and family of origin dynamics. She earned her PhD in counseling psychology from the University of Albany, and her dissertation was supported by the University of Albany Dissertation Research Fellowship Award. Dr. Austin completed a doctoral internship and postdoctoral fellowship in health service psychology at the University of Pennsylvania and is currently pursuing licensure as a psychologist in Pennsylvania. She has worked in a university and community mental health settings in a variety of roles, including intervention, assessment, outreach, and supervision. In research, teaching, and training, Dr. Austin strives to approach participant, student, and client care holistically in a way that exercises cultural humility, curiosity, and respect. Dr. Austin and Dr. Cinco, we're so grateful to have you here today and really looking forward to this really important discussion about the impact of trauma on trust and how relational trust and rebuilding relational trust is imperative to healing process. Thank you for coming today.
Thank you so much, Amy, for the introduction. I really appreciate it. And welcome, everyone. We are so excited to share this presentation with you and to hear your thoughts and feedback at the end. So I want to start by just saying hello. We are so happy you are here. We know it's a busy time, but I really think this presentation is important to think about how we might create better and more expansive feelings of trust with individuals who may have experienced trauma or harm on our campus. So today we will be talking about trauma and violence, including topics that might be particularly distressing, including situations of physical, emotional, and sexual trauma. While our focus today will be on rebuilding trust and supporting relational healing, We are aware that some topics brought up might be triggering for some individuals. So please feel free to turn your camera off at any time or virtually take a break or step out as needed. We really want to learn together, but we want everyone to feel safe. And I want to end this message with just recognizing that healing is possible. And we are talking about some of the impacts of trauma, but I know specifically in my work, it's something that I think often we can lose sight of when we're really in the thick of our trauma healing, that healing is possible. And so please remember that and think about how you might positively contribute to someone else's healing throughout this presentation. So Amy already gave us such a great introduction on who we are. It was quite long and extensive, so I really appreciate it. But we just have a couple key points about the two of us that I think is worth mentioning. So I will share myself and a bit of my background, and then I will let Crystal do so as well. So I, like Amy had mentioned, I'm a former pediatric mental health nurse. I also currently work as a sexual assault nurse examiner in Philadelphia. So this really has me look at trauma recovery through a holistic lens, and I particularly focus on the mental health impacts of trauma. I also am a clinical trauma specialist and restorative justice practitioner. So I also think a lot about how justice impacts recovery and really how that looks like for survivors and how it might look different depending on your life circumstances. And then my research mostly focuses on healing after gender-based harm and then trauma recovery in general.
Hi, everyone. It is, as Laura has said, great to be with you all. I'm honored to share virtual space with everyone today to talk about this important topic. Thank you to Amy for the really wonderful introductions. And so again, I'll just reiterate and share a bit more about myself. My name is Crystal Austin. My pronouns are she and her. I'm a licensed psychologist in Pennsylvania and a faculty member in the College of Education and Human Development here at Temple, where I have the privilege of working with fabulous faculty, staff, and graduate students in counseling psychology who are training to become mental health counselors and school counselors in the future. As a clinician, my work has been primarily focused in university counseling and community mental health, where I've worked with clients individually, with couples, with groups, and in terms of community outreach in supporting the mental health needs, which vary greatly in both settings. More recently, I have been privileged again to focus my academic energy in addition to playing a role as a faculty member here in conversations like this about the impact of trauma in various spaces, including educational spaces, consultation with folks who are in various institutions, because I'll talk about in a little while the impact of trauma and trauma conscious practice, not just in individual interactions with clients and patients and students, but in spaces. And in more recently, evaluation of trauma conscious intervention with, again, some fabulous Temple colleagues. In terms of my academic and clinical focus, an area that is close to my heart and an area that I have had the opportunity to do some work in is understanding the impact of racism-based trauma in terms of mental health implications. And so that's something that I'll spend some time talking about today as well.
Awesome. Thank you so much, Crystal, for introducing yourself a bit more. So we will start now by just having you check in with yourself and reflect on what you might already know about trauma. We know that all of us bring to the table different levels of expertise and lived experience in this space. And so I think it's really important to check in and think about what you know about trauma. So just silently, please feel free to reflect on these two statements. So first, in your own words, what does the term trauma mean? Can you think of examples that you've seen or heard about? And next, does this topic evoke any sort of emotional, physical responses in you that might be useful to be aware of when you discuss it with other people? So please keep these things in mind as we go through the presentation, and please take care of yourself as needed. So today we'll be talking about one, just what is trauma, to give us a shared language of what we'll be discussing today. We then will move on to how does trauma impact survivor trust and relationships with others, with some examples from our work. We'll then continue to try to understand how institutional oppression plays a role in relational harm. And finally, how can we in our varying roles rebuild trust and feelings of safety for the survivors in our professional and personal lives? So we'll start by talking about what is trauma exactly, so we can get that shared language and definition. So trauma certainly can be perpetuated by events people experience. So events and circumstances certainly cause trauma, but what really determines whether or not something is traumatic is how somebody experiences that event in the moment, and ultimately how it affects them long term. So this can really give us an understanding of why two people might experience very similar events, but have very differing reactions to the event that they experience, and maybe very different long-term impacts. So what is relational trauma? Relational trauma is this ongoing disruption of connection to both stability and safety in the context of a relationship with another person. And we know that relational trauma or interpersonal trauma can often perpetuate greater feelings and symptoms that can affect people's lives in the aftermath than other forms of trauma, because it really directly impacts trust and connections with others and even the world in general. It's often associated with abuse or neglect, and also attachment and toxic chronic stress. And because most relational trauma is ongoing, it often becomes a form of complex trauma, which can create specific and really significant barriers to healing for folks as they continue to navigate the worlds in which they live. So there are many different types of traumatic events people can experience in their lives. And so we'll list a few here, and I think you'll see more as we go throughout our presentation. So there's personal or private events, which is often where most of the relational trauma sits, but not always. There's childhood physical, sexual, or emotional abuse. There's intimate partner violence, sexual assault or rape, and then also examples of public traumas and events. So these are things that happen to communities. So for example, natural or person-made disasters, war, terrorism, or political violence, forced displacement, community violence, gun violence, and also this historical and intergenerational traumas, things that have happened to our ancestors that really are continuing to happen to us in these spaces due to discrimination and racism and all the different things that systems can be entrenched in. And we know that folks do not heal in a vacuum. So it can be really challenging because some of these ongoing situations and issues are still happening in our environment. And so that's also important to consider, not only how these things perpetuate trauma, but also how it impacts healing in the aftermath. So traumatic events can arise from individual, family, community, or societal experiences. So here we bring forward the Adverse Childhood Experiences Framework, which in its early days really focused mostly on these individual events like abuse, neglect, and experiencing different, what they call household dysfunctions. So having substance use or mental illness in the home, divorce, things like that. But as research has moved forward since the ACEs were initially conducted, more and more attention has been drawn to these community environments that can also perpetuate trauma. So experiencing poverty, discrimination, violence, poor housing. And so we really want to think about not only the individual relational events we might experience, but also our community environments and how that might impact our trust. So we're going to talk a little bit about trauma on college campuses, because for most of us, that is the commonality that we have. Most of us work at some sort of an institution, although potentially not all of us. But we know that 2 out of 3 college students report a history of trauma in childhood. And so here again brings forward these adverse childhood experiences people might experience coming into the college environment. And we know not all people come into the college environment as young adults, right? It could also be adult learners. So there's also this experiences of adult traumas that could also perpetuate and enhance the impact of these childhood traumas. And we also know that this list here is just scratching the surface of all the types of trauma people might come into the college campus experiencing. And students don't only experience trauma, faculty, staff, really anybody can experience trauma. And so we want to think about rebuilding these relationships at all levels of the university. It's also estimated that half of all undergraduate students are exposed to a potentially traumatic event during their first year of college alone. And this is important to be aware of because not to scare folks, but I think it's important to recognize that the transition to a campus community and all of the things that come with living within a campus community might impact the risk we might be exposed to in terms of these potentially traumatic events. For example, experiences of bullying, housing or financial insecurity, hazing, mental health or physical health crises, sexual assault, intimate partner violence, traumatic loss, gun violence. Many of these things we have heard in the news or have seen have impacted our campus and many other campuses across Philadelphia. So how does trauma impact survivor trust and relationship with others? The impacts of trauma are immense. And I think we often think about the physical and emotional impacts of trauma. But before we get really into trust, I think it's important to think about all the different facets of our life that trauma impacts. And then really thinking about how might that impact of trust manifest in these different spaces. So it can impact how we feel in our environments, the safety that we feel or may not feel, our financial situation, depending on what we need to do to heal from these experiences, our occupational and educational attainments, because the symptom burden from interpersonal harm can be immense and it can impact the goals that we have for ourselves. It can impact us socially, how we learn intellectually, and even how we feel spiritually within our bodies. So how does trauma specifically impact trust? Well, I think it impacts trust at all levels of ourselves and how we interact with the world. So trauma can impact our connection with ourselves or our trust in ourselves. Oftentimes, society sends us messages that we're to blame, or we did something to put us in these situations, or we didn't do enough. And those messages can be extremely problematic and can often make survivors feel like they can't trust their own judgment. Or maybe can't trust their own ability to manage their emotions. And so that can be really challenging when survivors are trying to form new relationships. It also can impact our connection with others. So if we think that others are trustworthy, what folks need to do to gain our trust. And also just things like intimacy, depending on the type of trauma you experience, certain others may be more difficult to trust. So keeping that in mind. And then also connection with systems. Unfortunately, people who are exposed to trauma, their trauma might directly come from systems they interact with. Or on the flip side, they might have been re-traumatized by systems when they were trying to seek help for their experiences. And ultimately, trauma can impact our connection with the world. This idea that, is the world truly a safe place? What is my place in the world? And really trying to rebuild that sort of connection with just the larger culture and society in which we live in. So Crystal and I are going to talk about some clinical examples about how a lack of trust might manifest in the different places in which we work. So Crystal, do you want to start with your story and then we can go back into mine?
Sure. And thank you for giving us that really salient overview of trauma and trust, Laura. Before I share about my example, which is not specific to an individual client that I worked with, but more along the lines of probably a culmination of themes and patterns that have shown up in my clinical work in both community mental health and university settings. I want to kind of name that, really echo something that Laura has said, because relational harm, or because harm or trauma can happen in the context of a relationship, healing can also happen in that context. But as someone who is either a professional helper or someone whose job is around supporting folks who are survivors of trauma or who are exposed to toxic chronic stress, or if just in your personal life you want to support someone who is disclosing to you their experience of trauma or a toxic chronic relationship concern, simply saying, "I'm trustworthy," or "I'm here to help," is not enough. It's about building or rebuilding trust, not only with you or potentially your role, your professional role, but in a person's lived experience with other people in general. So I just wanted to name that before I share this example. So we'll talk about an adult man client who experienced multiple ACEs, adverse childhood experiences, as Laura went over a little while ago, particularly in a lack of consistency and presence of a caregiving adult in his life growing up. Because his primary caregiver had experienced specific and collective traumas, so both specific events that happened to them, as well as exposure to these community and more collective traumas that Laura introduced earlier, they weren't able to be as present for their child as they might have liked to have been, because they were working through their own mental health concerns that were related to their trauma experiences during their life. The client, as a result, grew up in environments where they got messages, both directly and indirectly, like children should be seen and not heard, or boys don't cry, don't do that, and was told to stay in a child's place whenever they attempted to express what he was struggling with. He learned that his needs were not a priority and felt a sense of shame when even having the thought of expressing need for support. So that message was ingrained pretty early on in life. So the idea of vulnerability, or anything that felt close to it, came with a connection to feelings of shame for experiencing them. In counseling, he shared about experiences of isolation and depression, which brought him into counseling in the first place. And when I asked about support network, he described himself as having a lot of friends, but no one person that got to see all of him. He said, "I've got my party friends, I've got my sports friends, I have some things that people that I talk with work about. So my sort of more professional folks who I talk with about my work concerns and my academic journey, and a couple of friends who I know that when I'm really pissed off, I can call and just vent to. But no one gets to see all of me." And when we explored that in our work together, which was longer term work in terms of not only developing our relationship as a space in which the client could get to that part of disclosure, of sharing that not any one person got to experience all of him. He shared that it would just be too much for them. For me to feel, in his words, as though I could let everybody know everything or show one person all sides of me would be a really big risk, because they could say, "Oh, you're just too much," and abandon or choose to not be around. There's no quick fix or linear intervention for relational healing and counseling, because of the ways in which they impact us, especially when those messages are conveyed so early on in life. They play a big role in our identity construction, how we think about ourselves, how we think about the world, and how we think about ourselves in relation to others, what we can come to expect of others, what our role is in relationships. And oftentimes, based on lots of messages we get, including messages around our sociocultural identities, those expectations or those kind of identity those identity roles can be really limited in terms of who we are allowed to be and what about us we're allowed to bring in different spaces or with people. The therapeutic relationship, however, can be used as a model for a space in which a client can, at their pace, allow various parts of themselves into the dialogue that they have with a clinician. And we can explore how they build relational safety with others outside of therapy. So the longer term goal is to use the therapeutic relationship as a model for a space in which, through development of relational safety in our context, to be able to expand and extend that to other relationships in their lives, with the goal of eventually this client developing relationships in which they could experience trust enough to bring their full selves into that relationship authentically and genuinely.
Thank you, Crystal, for that example. And I think it's a really great illustration of really the immense amount of work and effort it takes on the behalf of the survivor who's trying to work through this trauma, but then also on the folks that are trying to help this person, and recognizing that exactly what Crystal had said earlier, that just saying I am trustworthy, I want to help is often not enough. It's showing up and continuously building that relationship over time. My clinical example is more of an example when you don't have a lot of time to build trust, how things might go wrong. And so I think it's important to also show how things can be mismanaged and things we might want to look out for. So my example is back when I was a nurse on an inpatient psychiatric unit for children and adolescents. This unit was an 18-bed unit. Folks were often there for about a week maximum, up to 2 weeks, sometimes longer, but typically it was quite a short stay. And I think we often struggled with folks who experienced histories of trauma because they often didn't know where to disclose that in their care. And then if they did, they weren't sure what we would do with that information. So this example, I had a patient who was a 17-year-old girl. I had worked with her for a couple days. I had went to lunch. And so when I went to lunch, we had found out, the care team, that we had to switch rooms. So most of the rooms on this unit were single rooms, but we had 2 double rooms just for spacing purposes for people it felt appropriate for. So many times kids in our unit wanted their own room. Totally makes sense. Now, people cannot always get that. So while I was gone, this person was told they would move from their single room to a double room. This person was extremely uncomfortable with that. From what it sounds like, their concerns were not heard. And it really put them in a situation where they got extremely triggered. They started throwing things, yelling. So I come back from lunch, smile on my face after eating my Kit Kat bar, and the unit is in shambles because this person is extremely escalated. And so that being my patient, trying to calm them down, pull them aside. And all I felt like the work that we had done to build up to this point seemed shattered. This person was sitting in the corner, back turned away from me, like I am a part of this system that caused this problem. And that made me feel extremely upset. It made me feel like everything that I did it even work? Did it even build rapport? But just sort of recognizing that some sort of harm was happening and not really knowing what it was. Asking if it was okay if I just sat with them quietly. They had said yes. So we sat on opposite sides of the room. They were facing the window. They were not even looking at me for a while, and just kind of sitting there, holding space, letting them calm down, offering them some water. Eventually, as silence can be therapeutic, as the silence sort of continued, this patient shared with me that they were actually harmed by someone in their family when they were sharing a room with an adult family member. And so just the idea of sharing a room with someone else puts them right back in that headspace where they could be harmed. And this is something that the care team had no idea about, right? And so I think it's a good example of we have to create space for people to feel like they can share their whole selves, but then also recognize that they're not going to trust us with that information out the gate. And so I just think it's a good example of how we can't, just because there's a rule that, when we put you in a room, you don't really have a say in it, we need to be careful when we have these hard and fast rules, because these things impact people differently. And this really caused her to have this really, really significantly traumatic, re-traumatizing experience, because she felt like she was not heard. So I think it's important to share where we fail and also where we succeed, because really, unfortunately, to have a trauma-informed approach, we learn from experience. And so now this is something that our unit changed their whole intake procedure on how we recognize who gets a double room and who gets a single room from this one unfortunate experience. So now I'll shift it over to Crystal, who will take us forward in this presentation, talking about institutional oppression and how it plays a role in relational harm.
Thanks so much, Laura, for sharing that example. And I just want to speak to that for a moment. It's such a salient example of what you said, that we can't expect a client or patient or person to disclose what their trauma triggers or activators might be for us, or the detail of their trauma history in general, sort of at the initiation of our relationship. They also may not recognize or realize what those activators or reminders of their trauma might be. So your client or patient may not have been made aware of how activating that might have been until the moment. And so the responsiveness of the unit, not only not only supporting that client and de-escalating in the moment, but then also questioning and challenging the systemic process overall, is such a wonderful example that I hope folks will kind of hold in mind when we come back to trauma conscious practice in just a few slides. So I'm going to talk about the impact of institutionalized or institutional harm and how that relates to trauma. As I mentioned, my work is focused oftentimes on the impact of racial oppression on mental and physical health to a degree, but mostly mental health outcomes, and how that might occur in systems. All individuals are made up of intersections of many, many sociocultural identities. Some of them are listed on this slide, and there are many more that we can list here as salient parts of who we are and what makes us kind of experience the world as we do. Unfortunately, related to those intersecting identities come with experiences of oppression, marginalization, and harm done to uphold systems of hierarchy like racism, sexism, cissexism, heteronormativity, ableism, classism. The list goes on and on in ways in which folks experience marginalization in our society. There is extensive and continuing research on the impact of oppression as a source of traumatic stress, different from singular or specific events in which an individual is able to identify this was a traumatic event. As Laura said in the introduction of trauma, an experience of trauma is what we what differentiates people's experience of something being a traumatic stressor or not. It doesn't have to be a singular event. And in fact, for many, it can be something that they're exposed to over the course of their life, like experiences of microaggression, discrimination based on sociocultural identities, and other forms of messages that are received that communicate to folks that they are less than based on identities that they hold. I want to share this quote that I share in almost every conversation that I have around the impact of institutional harm and marginalization. Resmaa Menakem, who's an expert on racialized trauma and trauma in the body specifically, talks about what happens when we're understanding or making assumptions about folks without thinking about how trauma could play a role in their experience. He said, trauma decontextualized in a person looks like personality. Trauma decontextualized in a family looks like family traits. Trauma decontextualized in a people looks like culture. What's meant by that is when we're not understanding the ways in which trauma can show up, both an individual's experience of marginalization and oppression based on sociocultural identities that they hold, as well as ancestral and historical trauma and how that impacts individuals and communities to this day. We make assumptions and generalizations and stereotypes of folks in ways that, again, are limiting in terms of who they can be and how they're perceived in this world. And so I encourage us to think about all folks that we encounter through a trauma-conscious lens because of the potential for exposure to these sorts of toxic chronic stresses. I also want to name, before moving on to the next slide, that we talked already about some important examples of how trauma can occur in individual relationships or in situations in which the harm was done by a person. Institutions can also do harm. Institutions are oftentimes entrenched with, as Laura said earlier, systems of hierarchy that promote or perpetuate forms of oppression like the ones that I talked about a couple of slides ago, including institutions that we might work for or exist in. They have histories of and ways of continuing harm for folks, especially folks with marginalized identities. And so I encourage you to consider the ways in which the institutions that you exist in, work in, operate in, are impacted by historical harm done to other people, and how that might show up in the room when you interact with a client, student, patient. Although you may not directly feel as though you have connection to the ways in which oppression is perpetuated, we're all playing a role in society, a society in which oppression exists. And so I encourage you to think about sort of how that might impact the clients or patients or students or persons' experience of trust in you, of the setting that you're existing in or communicating or working in, and of the institution broadly. So we're going to share a couple of clinical examples, again, relevant to this. I can start first, if that's okay, Laura. Okay. So similarly, I'll share an example from my clinical work that is more a culmination of experiences that clients shared with me in my work in college counseling and university settings. So a college student who was a first-generation college student, first-generation American, and a person of color who had not been to counseling before, worked with me. They shared about their interactions with the financial aid office, about receiving and validating messages about how their parental contribution should be more than what they're saying it was, which was zero. Or that, textbooks are just whatever amount of money, and validating what that amount of money could mean for someone. They had interactions with peers in their first semester of college, during which they were exposed to classist microaggressions like use of language about folks who couldn't afford certain things, or to socialize. They needed to pay to go to particular places rather than going to, say, the dining hall for lunch. So it was limiting in terms of their ability to develop a support network as well in this new environment. They also had some interactions with professors and academic advisors who had suggested they may be better suited for particular courses or majors or career paths, like education over engineering, based on gender role assumptions that those folks had for them and who they assumed would do better in those various professions or majors. Their only interaction with a mental health professional was during childhood, when they briefly interacted with a family social worker who seemed kind to them, but the adults in their life warned them against opening up to the social worker out of any worry that they would get in trouble, because the adults in their life had interactions with systems in which disclosure or sharing with someone who represented a social worker or caseworker or an agency related to mental health might mean removal from home, or other forms of punitive interactions with those systems that might relate directly to bias that exists and who's reported for abuse versus who might not be. So when they met with me in the University Counseling Center setting, because they were experiencing some anxiety symptoms related to adjustment to college, there was tension between wanting support, which is why they chose to come in, and wanting to not share much of anything with me. There was tension in my role, and as I said earlier, the idea of I'm trustworthy, this is my role, isn't sufficient. That was a lesson learned for me in my early clinical work, because sometimes I said things like that directly, and other times I just felt it really strongly. Why won't this person just open up to me? I'm here to help. This is what I'm wanting to do and here to do. My work involved validating that talking with any new person, and especially one associated with this mental health system, associated with this university in which they've had some not positive interactions with other adults in this space, and especially the one-sided nature of counseling relationships may be uncomfortable for many clients. I talked with them about their therapy process. I defined confidentiality and what that means in the counseling space and at this counseling center. And I talked about limits to that, to confidentiality. And I clarified that we can use this time in the ways they chose around their goals and follow it at a pacing that made sense for them.
Thank you, Crystal. I really appreciate that example. The examples I have, gosh, there are unfortunately many examples where I've experienced this in clinical spaces and academic spaces. I think in general, working as a sexual assault nurse examiner, one of the major barriers I come across time and time again, and there are so many patients that one example really isn't enough, is just our relationship with law enforcement and what that looks like for folks trying to seek help after experiencing sexual harm. So that is something that we are continually working on, trying to think about solutions. But it definitely, in my role, has created barriers to supporting folks' health, because even though I am not technically affiliated with law enforcement, I am the next step. And so often there is a misconception that I am a part of those systems. And also by linking the evidence I gather to their police reports, in a lot of ways, I am a part of that system in a way. And so thinking about my role in that and something I've continually grappled with. A more specific example I would also like to give is just in academic settings, trying to do community engaged research. I've come across a lot of different examples and organizations where I would love to partner with them on projects, but they come with a lot of distrust for academic institutions in general. So for example, I recently started working with a trans and non-binary serving organization for an LGBTQ study I am working on. And it took about a year of relationship building and really laying out expectations ahead of time and laying out their expectations for me and things I need to meet in order for them to collaborate with me, to continue to work with me. And they had built all of these procedures when partnering with academics because of previous harm they have experienced. And it makes total sense, right? But it's hard as somebody who tries to be trauma informed and wants to be survivor centered to not take that sort of distrust or policies put in place to make sure that I hold up my end of the bargain, to not take that personally. It's not that they don't think I'm a good researcher or they don't think anything about me as a person. It's because I'm a part of a system that has harmed them in the past. But I really had to separate that feeling of inadequacy, that am I doing something wrong? Am I coming across a certain way? To recognize that there is so much more. And it's my job to continually rise to the occasion and try to put my best foot forward and to listen and learn from the mistakes of others to hopefully rebuild that trust for future situations. But I know that it's hard not to take things personally when you're really trying to do a good thing. So that's something else that I think is important to recognize.
Absolutely. Before we continue on to talk about the rebuilding of trust and feelings of safety for the survivors in our professional and personal lives. A quick webinar note. We encourage you to share questions and to do so in the Zoom webinar space. I believe that attendees, participants have access to the Q&A feature. So please share your questions there. Thanks, folks. Something that you spoke to, Laura, that I just want to echo again is the importance of consistency and showing up, knowing that there may be experiences in relation to either in our professional roles or in our personal lives, experiences with folks who are survivors of trauma, that in which they may expect folks to give up on them or to interact with them in ways that are dismissive, and that for that to be it, especially when there's a tension in an interaction that they have with you. And so in our roles, being consistent in showing up and communicating directly and indirectly that we are going to be with them through that process of support and healing is really important. So let's move on to talking about, or really continuing the conversation of building and rebuilding trust and emotional safety for folks who are survivors of trauma. Bruce Perry, who's a psychiatrist and trauma expert who folks may be familiar with being the author of a book called The Boy Who's Raised as a Dog, and another book that was co-authored recently with Oprah Winfrey called What Happened to You, said this, and it really resonated with us and with the topic for today. Fire can warm or consume. Water can quench or drown. Wind can caress or cut. And so it is with human relationships. We can both create and destroy, nurture and terrorize, traumatize and heal each other. We've spent a good amount of time today talking about the ways in which harm can occur in the context of relationships with individuals and systems. And as we shift to talking about ways in which we can support survivors in their healing process, I encourage us to hold on to these words, that although harm can be done in the context of human relationships, there is power in relationships as a form of healing as well. Trauma-informed care, which is a term that folks may be familiar with, is really broadly about the idea of shifting the conversation from what's wrong with you, having an interaction with someone, perhaps in your personal life, where you just have a kind of a quick interaction with a small amount of time that's based on a little bit of data, but the end result of it could be frustration with another person, and the question popping up for folks of what's wrong with that person. Or as Resmaa Menakem said, we might decontextualize the nature of what's happening and say that it's, oh, that's just their personality. Trauma-informed care is about understanding all folks with whom we interact through a trauma-conscious lens, meaning there's possibility that trauma is a part of their lived experience. In shifting the lens through which we understand them from what's wrong with you to what's happened to you that's contributed to how you show up in a space, including why someone may not be disclosing information to you or experiencing trust or saying directly, I don't trust you, or I don't trust anyone here, right? So trying to understand through a lens of what has contributed to how someone shows up in a space. It's also about moving the conversation to understanding when we are part of larger systems, how am I in my role, and how in the systems that I'm part of reenacting traumatizing relationships or experiences that a person has had, and how the other, I guess the next step to that is how can we shift those systems to be more inclusive and accommodating so that folks can experience more safety relationally as well as within the system that we're in. The Substance Abuse and Mental Health Services Administration, SAMHSA, has done a lot of work in understanding and sort of conceptualizing this idea of trauma-informed care and for use in various spaces and organizations. And so it's not just a clinical approach, but it's something that can be used in school settings, healthcare settings, businesses and organizations. And part of their model talks about the R's of trauma-informed principles. Realize, so as we've been doing today, talking about the reality of how trauma can show up in different ways for folks, so realizing the impacts of trauma, recognizing some of its signs, responding with trauma-informed care. We'll talk about that a little bit in just a little bit. Resist re-traumatization. So being aware of the ways in which an individual may be re-traumatized, like the example that Laura shared earlier, shifting policies, practices, or ways of engaging with someone in order to limit or prevent the likelihood that we're going to re-traumatize them or trigger a reminder of their trauma experience. And reflect. Think about your role in the process. Reflect on your own relationship with mental health, with trauma experiences, with toxic chronic stress, as well as your role either personally or professionally. Set clear and reasonable boundaries for yourself and with the person that you're supporting. And we'll talk a little bit more about this, but really prioritize your own care and well-being, because as folks who are supporting survivors of trauma, we can also experience the energy, the stress of that as well. And so taking care of ourselves so that we can continue to be present and show up for those who we choose to support. Re-traumatization. So resist re-traumatization was one of those SAMHSA principles that I just went over. So we thought it'd be important to define re-traumatization. It's a reactivation of traumatic responses whenever individuals are exposed to their traumatic history. So an example in a clinical setting, or when talking with a medical provider about their experience of trauma, exposed to those histories, or having to recount the details of a trauma, or triggers, reminders of, or activators of their trauma experience without sufficient tools, both internal and external, to support or manage their emotional, behavioral, and physical reactions. Our brains and bodies oftentimes go into protective survival mode, especially when we are reminded of a trauma experience. We utilize the resources we have to respond to that trigger or activator, and sometimes the capacity to be able to de-escalate and support ourselves in those moments may be impeded by our brain survival state in that moment. And so if we're supporting someone in a state of escalation of their trauma response, it's important to be aware of the coping mechanisms that folks may use when experiencing a trauma trigger. Resisting re-traumatization in a holistic way involves integrating principles of what SAMHSA refers to as the trauma-informed principles into your organization or your work setting or your class space. And it doesn't have to be in situations in which you know that you're working with a survivor of trauma, because again, a trauma conscious lens is applying these principles regardless of whether or not you know of a specific diagnosis or presenting concern or life experience. We're just interacting with all folks through this lens. The SAMHSA principles are empowerment, voice, and choice. So how are we supporting the agency and autonomy of the survivor or that we're working with directly, or the folks that we're working with in an environment? Part of trauma, overall trauma experiences, especially relational trauma, is a loss of agency and autonomy. They didn't choose what happened to them. And so in the healing process, it's really important for survivors to have experience of choice. Peer support, so ways of connecting with others who have similar experiences or life events, to be able to experience a sense of validation of some of what they've gone through. Collaboration and mutuality. how can they be involved in the process of healing, or their process of whatever it is you're working on, their learning experience, if you're in education space, or their healthcare. Trustworthiness and transparency. How do you build trustworthiness? By being clear about the role that you are in, the expectations that you have for the process, and inviting them to participate in sharing their expectations as well, so that there's a mutuality of transparency in your relationship. Safety is important to consider physical safety as well as emotional safety in spaces. So what are we working towards, so that folks have a clear understanding of the process that we're doing together in order to work towards safety. Safety in the physiological sense especially, but both emotionally and physically, cannot occur if someone is not experiencing regulation. So how do we feel grounded in our bodies? Supporting clients in self-regulating or experiencing a calming down, which, as I mentioned a little while ago, when our brains go into that survival mode, when a trauma trigger is activated, it can be challenging to do. It's a really important part of safety. So thinking about that as we support survivors of trauma, and I go back to Laura's example earlier of sitting with the client who was activated and giving them space to sort of self-regulate before moving into any conversation or intervention. Finally, SAMHSA presents the sociocultural and historical concept principle as a sixth principle within their model, but the way that we've tried to depict it on this slide communicates how we're thinking about it. It's important to consider a person's sociocultural identities as well as their own personal history and the history of folks within their community in interacting with the various systems that we live and work in. And so when thinking about each of the other 5 principles, consider sociocultural and historical context as well when thinking about the client's identities, worldview, and experiences, as well as your own, in checking your own biases and how they may show up in various ways. We want to talk about responding to disclosures of trauma. If someone in your personal or professional life shares with you that they have experienced a traumatic event, listen, allow them to lead the conversation. So thinking again about that empowerment, voice and choice piece. Avoid asking questions. Use the language of the person with whom you're speaking. We don't want to kind of add on pathologizing words or experiences or labels that are not their own, which could increase or perpetuate feelings of shame that they may be holding. And let them know that you're with them in this and that you appreciate that they trusted you to share this. Believe them, affirm that their experience is real and valid. So many of people who've experienced trauma get messages concurrently that invalidate that experience was real, or as Laura mentioned earlier, that they played a role in it happening in some way. And so we want to do the opposite, remind them that it's not their fault, and clearly communicate that you believe their experience. Support them, thinking about the fact that there are lots of folks in this space and we serve in different roles, recognizing the limitations of the role in which we are in professionally and personally, and refer and connect to folks who may be able to support differently. So support them in ways that make sense for you and what you're doing, but also know that you can refer to other supports like counseling. And so promoting a trauma-conscious interaction, again, can happen in spaces where we're not working, or we may not know that we're working directly with survivors of trauma. This can be applied in all of our spaces. So I encourage you to think about how, as we go through each of the SAMHSA principles of trauma-conscious interactions, and Laura and I will provide some examples of each from our context, think about how in your role it would make sense for you to incorporate these principles and maybe come up with an example for each. So the first one is sociocultural and historical context, as I've started to talk about already. An example of that comes to mind for me is really keeping in mind the use of language that has been used pejoratively and negatively to communicate labels about folks in biased ways. And sometimes in the settings that we live and work in, the language may be so normalized that we don't realize the history behind it as really problematic. For example, ableist language. And so when interacting with clients in that setting and with colleagues or peers, checking to understand the ways in which bias may be communicated by either language that is pejorative or comes with a history that relates to harm, or is not inclusive to all of the folks that you want to be welcoming to in that space. That's one example. Laura, did you want to share one?
Sure. I think that there are many, and I think you did a good job talking about it comprehensively. One of the things that shows up a lot in my work is gender and sexuality, and thinking about how that plays into it. So thinking about things like, how do we sensitively really hold space for the identities that we can see, but also potentially the identities that we don't see, and recognizing there is so much more to folks than what we see on the outside. So I think really just keeping that in mind and thinking about ways to organically let folks bring forward the ideas that they think are important to share, but also not forcing that experience. So one of the things that I think of is this idea of pronouns. And I think we're always trying to think about, how do we best communicate that? How do we even talk about that? And so one of the ways for me that, at least in my work, that I found is sometimes forcing everyone to go around and say pronouns is not necessarily what folks want to do. They might not feel comfortable sharing their pronouns in spaces. So maybe modeling that behavior and saying, my name is Laura, I use she, her pronouns, and continuing on and letting folks have the option of sharing their pronouns as opposed to making it mandatory might be an example of that.
Absolutely. Thanks for sharing that really salient example. Something else that I'll add, that as a result of a conversation with a recent graduate from the counseling program who's now a clinician, in the beginning of a semester, when I usually ask folks to go around and introduce themselves and have included an invitation to share pronouns as part of that, something I've added to that introduction is, this is my name, these are my pronouns. And I encourage you to, although you may already know folks in this space or had class with them last semester, be mindful of the names and pronouns that they share, in recognition that those may be different from what they were the last time they introduced their name and pronouns, and that's okay, right? So the next idea is collaboration and mutuality, which I introduced already on the previous slide. How can you involve someone in the process of how you're supporting them? Really focusing on the idea of agency and autonomy within that process. Another way to think about collaboration is, with whom in the person's life might you collaborate to support this process? Thinking about work in school spaces, can you communicate with parents and caregivers or other adults in that person's life about the things that you're working on in the school setting, so that there's consistency and continuity across two spaces in which they spend a lot of their time, to have a shared language, a shared process, and also empowering caregivers to be a part of their child's process of support.
And then building off of that idea, I think really trying to collaborate and work with folks themselves. I think, especially as speaking for nurses, we often assume what patients might need based on previous patients in the past, or what we've learned in our textbooks is what folks need after experiencing these certain events or certain health conditions. And so really collaborating and thinking about, what does recovery look like for you, whether it's in the trauma space or maybe even just in a general health space? What does recovering from a heart attack look like for you? Maybe for some, they're really interested in intimacy. Maybe others are trying to get back to some sort of an exercise routine that helps them decrease stress. So really trying to collaborate and figure out, what does a recovered self look like for you, and how can I help you get there? And does it involve these formal services or systems? I think it's also important to hold space for the things that people do in their daily lives that can support their health and their healing, and also considering that just as important as what we provide through systems.
Absolutely. Yeah. In terms of safety, as I mentioned earlier, physical and emotional safety are important for us to consider. So in terms of physical safety, have them be aware of, say, protocols for exiting a space, and awareness of where those exits are, in order for folks to feel as though they have a sense of agency and control in terms of their physical surroundings, especially for folks who've experienced trauma in the context of harm, um, in community ways or in terms of physical violence. Having a sense of agency in that way is important for them. With regard to emotional safety, supporting, and I think this is a kind of collaboration between collaboration and safety, the idea of setting expectations or ground rules or norms within the context of your working relationship. Have the person being a part of that process of talking about what the expectations are and what the process is that we're working on together, as well as upholding those. And if you are in a position of relative power or control in the working relationship, letting that person know that you are also going to participate in those same ground rules or norms that you've established together. That can speak to the emotional safety piece.
Thank you, Crystal. I think that is so important. Really creating norms can help set the foundation for a good relationship and can create a place to return to if harm occurs in the context of that relationship. Also, in terms of safety, I think about psychological safety. So creating spaces where folks can feel hopefully eventually comfortable bringing up concerns as they come up. So something in education spaces that I've tried to build in, particularly in my research lab, is having community building circles at the beginning of lab, really focused on values, intentions, people's experience as they interact with the research and the work. And I hope, and I've heard some feedback, that by having that intentionally carved out space where folks can bring concerns, they feel more comfortable doing so because there's more permission to do so and a structured space. And when the circle closes, we could transition on to more agenda items. And so by witnessing others opening up and share, it also, I think, creates that experience of potential psychological safety.
I smile because that was one of my favorite parts of grad school, was being a part of a research team that had a similar practice where we really got to know and support one another and connect to the work that we were doing, which was very much personally connected and motivated in that way before just focusing on the academic context. I observed that in working on evaluations and observations in school settings in which educators seek to know the whole student. Rather than who they are academically, what their grades are, focusing on kind of making sure that they meet these academic benchmarks only. It makes the world of difference when all people feel seen and heard and understood for who they are as a person, and not just what their productivity is or what their job is in a particular space. As far as transparency, I shared a little bit about this in one of the examples I gave, the clinical examples I gave earlier. To the degree possible, share about the process of what you're doing, so that there isn't as much ambiguity or vagueness of what the person can expect when interacting with you. So in talking with clients who I'm just starting to work with, all clients, I'll talk about sort of my style as a clinician, some of the things that we might do in the counseling space, confidentiality and what that might mean here, and invite them to ask questions in service of this concept of transparency. In an educational space, that might look like, or in working with children, that might look like explaining why you gave or any student, why you gave a particular assignment. What's the intentionality behind it? How does that connect to a larger goal? So those are a couple of examples of transparency and how that can be empowering in a space.
And I think also, just to build on transparency, in more of a clinical role, I also think of it as consistency. So if you tell your patient that you will be back at 1 p.m., really do your best to meet that expectation. Because like Crystal had mentioned, Oftentimes, folks who've experienced harm and re-traumatization might expect us to not hold up to our end of the bargain, or might expect us to stop showing up. And so while for us, it might be, oh, I'm just 10 minutes late, for somebody else, that could set them even further back in their relationship, rebuilding trust with you. So really trying to, if you set an expectation, making sure you are transparent with your limitations and make sure you meet what you do say you can to the best of your ability.
Yeah. Empowerment, voice, and choice is what the title implies, opportunities to seek empowerment for the folks with whom you interact. And so that might mean choices it should mean choices in their treatment process, if you're a clinician or a medical provider, some sort. If you're an educator, choice in the ways in which you're learning or presenting knowledge that they've learned. If you are a friend or supporting a survivor in your personal life, choice in terms of how you can be support to them. Sometimes when folks are seeking to support a loved one or someone in their personal lives, the question that comes up first is, what can I do for you? Right? I really want to help. What can I do for you? And when someone is experiencing escalation or just feeling overwhelmed or flooded with their experience in the moment of stress, it can be really difficult to think of what you can do for them. So the response might be, oh, I don't know, or nothing. And so giving them options and inviting them to choose from those options may, one, give some structure that could be really useful at that time, and two, give them a way to exercise voice and choice. It might also have to do with something that is not directly related to supporting them in processing their trauma or in their healing process. So it could be, do you want to, we've got break time. Do you want to play a game, or do you want to read quietly? We have an option of how you can present the information you learned for this research project. Do you want to give a talk, or would you prefer to record something virtually and share that? So, just different options in general can be beneficial in promoting voice, choice, and empowerment.
And Crystal, I think you covered most of the things here, but just to build off of that, another way to promote empowerment is to look inward at our own biases of how we feel people who experience trauma are. So there's often a common misconception that people who experience trauma are broken, or people who experience trauma did something, or there certain types of people experience trauma as opposed to others, right? And so whether or not we communicate that assumption can be clear in ways that aren't communicated. And trauma survivors, for the most part, are pretty good at picking up on those sorts of things, and people have those internal biases. So recognizing that people who experience trauma are reacting in perfectly normal ways to, people say, abnormal experiences. We know trauma is not abnormal, unfortunately, but really not, it should not be normal experiences. So also just keeping that in mind when you're reacting to folks, and not further pathologizing their experience.
Absolutely. Yeah. As we start to wrap up and hold some space for questions, we want to remind you of the importance of taking care of yourself, regardless of your role in supporting your role professionally or personally in supporting someone who's a survivor of trauma, or working to incorporate these trauma conscious principles into your setting. Compassion fatigue is real. The impact of supporting folks who share about or disclose their experiences of trauma or other forms of stress can impact the helper in that situation. And so it's really important for us to consider how we are in sustainable and accessible ways taking care of ourselves. I emphasize those points because sometimes self-care, the picture of self-care can be a bubble bath and a face mask, which I like both of those things, but they're not accessible or meaningful or sustainable to all of us all the time. So I encourage you to think about ways in which you can incorporate care into your life in different ways at different times. Various forms of care might be helpful for you. Another point I want to highlight around care is oftentimes it's very individualized through our Western framework, we oftentimes individualize things, and healing happens in community. And so seeking care in the context of community is absolutely encouraged as well. That might mean community with folks who are in similar roles to you as well, so other helpers potentially. Other forms of preventing compassion fatigue include debriefing after difficult events, so particularly difficult interactions with a person that you're supporting, in which you're kind of left holding some of that stress or questions about how you supported them or how you did in that interaction. Debriefing with others, a supervisor, a colleague, etc. Setting clear boundaries around what your role is, what you can do to support them, and what is beyond what you have the capacity to do, and supporting them and connecting with others who might have a different capacity to support, and creating overall cultures of safety, respect, and as we talked about, those trauma conscious principles. Research is growing and in wonderful ways supporting the idea that trauma conscious environments are not just beneficial for the folks who are on the receiving end of those policies, principles, so clients, students, patients, etc., but the providers as well, because it shifts the environment overall, and it also turns those practices into thinking about how we treat employees, staff members, colleagues in a space. And so it certainly can influence the culture of the space you're in overall. If you can't tell, we're a fan. As we wrap up, we want to encourage you, as you perhaps have been doing throughout this talk, to reflect on what you're going to do with this information. We hope that there has been some opportunity for learning new information or thinking about information you knew in a different way. And so encouraging what you've learned or what you'll do with the knowledge you've got for today. As Laura mentioned in the introduction, there's personal connection. So the emotional reaction, your feelings, we encourage you to take care of yourself as you sit with some of the things that we've talked about, and as you think about and plan for how you'll care for others moving forward, and how you connect in community with others too. So we hope that there is space for that today and your weekend and beyond. We'll open up for questions now, but we want to thank you all very intentionally for your presence today, for your energy, your engagement. We've included our email addresses here, and we can try and figure out a way to share this PowerPoint with you all so that you have the email addresses too. Thank you, everyone.
Thank you. And now we will open it up for questions. Amy, were you going to facilitate that, or should we just jump in the Q&A? I see that you've been thoughtfully answering folks' questions via the chat, so I'm happy for us to highlight some of those, or what do you think is the best approach?
Well, I want to just thank you both for just a really solid presentation, really walking everybody through, whether it's the first time somebody has thought intentfully about trauma and relationships, or whether they're far in. I think you offered something that really resonated with everyone in the audience, and I really want to thank you for the thoughtful design and content that you've brought to us today. I think that we don't have the ability for people to ask us directly questions beyond the chat, or beyond the Q&A. So I think it would be great if folks would feel welcome to please put any thoughts, questions, even just how did this hit you, to generate some discussion at the individual systems organizational level. And while we're waiting for those thoughts to come in the Q&A, maybe Dr. Cinco and Dr. Austin, you're able to kind of look at some of the things that were posted in there and responses. How's that sound?
That sounds good. Thank you. And again, thank you, Amy, for responding to some of those questions earlier. I'm scanning the questions that have been shared via the Q&A earlier in the presentation. Laura, is there one that you've noted that you want to speak to?
This one I think could be interesting. And Crystal, not to put you on the spot, but I would be curious your reactions, and I'm happy to share some as well. Someone asked, how do we think about trauma-informed policies. So they said, I can see how there might be a policy, but how do you create the carve-outs? How can we think about inclusive trauma-informed policy?
I think that that is a great question. And there are some great resources that I made note of that I wanted to name as well, because the lens of understanding folks through the context of trauma is one piece of, but as the question says, sort of embedding it into policy is important. So one piece I think is flexibility and responsiveness. And so the rigidity that exists in a lot of our policy in various spaces is oftentimes not trauma informed. And so as you're reviewing policy of an organization that you're a part of or an institution, acknowledging the ways in which the policies exist that are in ways that are rigid. And so opening up opportunities for flexibility in how someone engages, for example, I'm thinking about in terms of class presentation, how someone engages with the content, rather than having, and also checking our own biases about what sticking to the rigidity of that policy means for us. Is it because when we went to school or when we were in this space, it was exactly like this, and so we've got to keep it that way? You know, what is the intention behind it, and what does that communicate to other people? So although it's difficult to talk about policy broadly because it affects it shows up differently in different organizations or professional spaces, I would encourage you to review some of the policies that apply to your workspace and consider the rigidity of them versus flexibility and expansion of how folks can show up in that space.
Yeah.
There's one. Oh, sorry. Yeah, Amy.
I was just going to add to that about recognizing that policies also come from their own place of historical consideration, and that what was happening in the historical times that the policies evolved, and where the policies themselves established in light of active trauma that was happening, but not an understanding of trauma-informed thinking at the time when and so recognizing the history that goes with the policy, as well as when the policy has been enacted in the past, what's everybody's memory of that historically across time, and how does that impact even their ability to openly look and explore an existing policy with flexibility, so applying those same trauma-informed SAMHSA principles with that historical context to the look at the policy is going to be really important.
That's a great point. Thank you, Amy. One resource that I did want to share that it seems to be based mostly in medical systems, but I think that they have some guidelines that could be beneficial for other forms of policy reform, is the Trauma Informed Care Resource Center. It's traumainformedcare.chcs.org. And again, they just have a lot of resources for the shifting of policy and systems organization into ones that are more trauma informed, embedding and incorporating those SAMHSA principles. I saw another another question that speaks to sort of what Amy was saying around history. Is it okay, Laura, if I jump to that question? Okay.
Go for it.
Someone said, speaking of historical trauma, how do you identify between culture and trauma, specifically for folks who've been historically and groups who've been historically marginalized? And I just want to thank you for that question, because it reminds me of something that I really wanted to make a point about today. In talking about marginalization and the impact of, in my work, racism-related trauma, and more broadly, oppression, and how that connects to experiences of complex trauma, it is not the person's identity that causes the trauma. It is not the person's identity that in and of itself is a risk factor for trauma. It's their experience, it's the identity in the context of a world that exists in systems of hierarchy to promote and perpetuate marginalization of people. So I want to be clear in saying that the person's cultural identity, sociocultural identity, sex, gender, sexual or affectional orientation or identity is not what causes the trauma. It's holding that identity in a world that invalidates and seeks to erase those groups of people through marginalization.
Dr. Austin, thank you so much for bringing that up, because I think a lot about how internal belief systems about self are formed within these systems that are very traumatizing. And so for a person, a part of the healing journey is that recognition of where is my authentic self, where is my identity embedded in, where do I feel safe or not feel safe within relationships, within individual one-on-one relationships, within a family system, a community, a school, an organization.
Mhm.
And 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 as we engage with anybody that we're interacting with, recognizing how their internal belief systems in and of themselves may be impeding them from truly living in their full authenticity, and how we can, how we can respond to that in every aspect that we do.
Absolutely. Absolutely. Thank you.
And then in looking at the Q&A, I'm sensitive we only have a couple minutes left. It looks like the majority were answered by Amy, so thank you so much for that. The only two lingering ones, the first I think I can touch on, and then I think the last one would be maybe a good one to end on. So the next one talks about, and thank you so much for sharing, one of the participants in this discussion shared that they're currently on placement in a prison, mainly dealing with sex offenders, most of them who've had ACEs. And they're talking about how they want to also work with them through a trauma-informed lens. And so I think that that is a really interesting point. And it's this idea that often folks who cause harm have experienced harm themselves. And so when we're thinking about working with people who've caused harm, I think there's a lot of different philosophical ways in which folks approach that work. But I am someone that comes from a place that believes in a path to redemption and restoration with the proper supports. And so research does show that when we work with individuals who've caused harm, to really center the harm that they caused and focus on impact rather than potentially just putting them away in carceral systems where they have to deny, as opposed to really looking at what they did head on, but then also helping them heal themselves. It can decrease rates of recidivism for things like sexual crimes. So we do want to think about different ways we can work with folks who've also caused harm. And if we can work with them in a trauma-informed way, it could also hopefully help impact outcomes. So that's just one thing I wanted to touch on. And then finally, it might be a good take-home message. Someone had asked just specific insights on how we could apply this to teaching. So Crystal, do you have any quick ideas of things you incorporate to be a trauma-informed educator?
Sure. Flexibility, voice and choice, those are the pieces that for me are relatively easy to incorporate into both practice and teaching with students at the university level, as well as I think can be applied in working with folks at all points in the lifespan and education systems, and doing so in ways that I recognize that we have lots of constraints in terms of educational requirements, curricular demands, the systems in which we work in, which we may experience a lack of empowerment in sometimes too. So thinking about ways in which you can exercise the relative power you have as an educator to shift the policy, at least in your classroom space, to honor the whole person of a student. I'm not encouraging or suggesting that a teacher has to be the counselor and the social worker and the educator, but recognizing that the ways in which what's happening for a student before they come into your classroom, or what they're thinking about happening for them after they come into your classroom virtually or in person, is going to impact how they show up in that space, including how much of the information cognitively they're able to retain if they're experiencing a state of de-escalation or distress. And so, Amy, if it's okay with you, I'd like to share something that you've shared with me, I've learned from you. Supporting in the beginning of a class meeting or a session, sort of a grounding or a transitional point of sort of, we're going to come in and focus on what we're here to do in terms of the learning in just a moment. But as you're entering in the space, Amy oftentimes will have music playing, something grounding like that. we're starting with a connecting question that has nothing to do with whatever we're talking about academically, but as a way to signal to students that I care about you as people beyond, as we were talking about earlier, what you can do academically or what the work is that you can produce. And Laura, the example that you shared about your research team is, I think, a really great one as well.
Awesome. Thank you, Crystal, for answering that so comprehensively. I really do not have much to add there, and I'm aware we're at time. So I just want to take the opportunity to thank you all for your presence, your energy, and engagement. I know I really enjoyed, Crystal, I loved working with you. Amy, it's been a joy to always work with you. So I hope we can do more of these, and please feel free to reach out. Our emails are right here. So thank you so much.
Thanks, everyone. It's been a pleasure.
Thank you all for coming. At the end of this, we will pull and package this presentation in a link, and we'll be able to share some of the resources and the recording of the video if you'd like to rewatch it. Thank you all so much for coming, and I hope you find some regulated moments and some meaningful relationships this weekend. Bye.